specialist. And I don't think that we have got any better person in India than Dr. Shovan Saha to address this particular question. So we all know Dr. Shovan Saha. He is a specialist in low technology assistive devices, occupational therapy, and hand rehabilitation. He serves as an associate professor in the Department of Occupational Therapy at Manipal College of Health Professions, Manipal. And Dr. Saha holds a PhD from Manipal University, having done his master's degree at LTM Medical College, Mumbai, and his Bachelor of Occupational Therapy coming from Srinagar. He serves as a guide for Master of Occupational Therapy students, specializing in hand and musculoskeletal conditions at Manipal University, and is the founder and chief resource person for Asia's first live hand splinting program, having completed 76 batches at Manipal University Hospital. He has effectively treated clients with a diverse array of neurological and physical disorders and has fabricated over 10,000 splints. In addition to his professional membership, Dr. Saha serves as the president of the Society for Hand Therapy and is a life associate member of the Indian Society for Surgery of the Hand. He is also a member of Indian Academy of Cerebral Palsy and Indian Federation of Neuro Rehabilitation. And to say very few selected achievements, he has been nominated as a hand therapy educator by the International Federation of Societies for Hand Therapy in November 12, 2012, and his appointment as human factor consultant to Handicap International. He has authored numerous scientific papers and book chapters, and he holds copyrights for a variety of unique patents. He is an invited speaker at numerous national and international forums, including the WHO session on assistive technology, and he has been to various American universities to deliver his lectures and Indian Institute of Technology. So he also serves as a technical member for BIRAC Fellows through TIS Mumbai. And these are all very few selected achievements of him. And in case if you are ready, and I hope that we all are ready, and I would like to convey the chair, or I would like to transfer the chair to transfer the meeting to Dr. Shovan Saha. Sir, please.
Yeah, thank
Sir,
you.
Shovan, sir.
Yeah, am I heard? Can I?
Yes, sir. Yes, sir. You are audible, sir.
Okay, okay. Thank you. Yes, thank you, Dr. Ganesh, for that wonderful introduction. And yeah, I will just quickly. Is my screen visible?
Yes, sir. Not your screen. Yes, sir. Visible, sir.
Slides are changing, right?
Yeah, slides are changing, sir.
Right, great. Okay, so good evening, everybody. Thank you, ISCP. Thank you, Mallikarjuna sir, for having me here. And we really look forward to this entire month of endeavor by IACP, to serve the cause for children with cerebral palsy. So like the various speakers I'd seen, of course, I didn't get time or opportunity to attend the previous presentations, but I'm sure they definitely would have had a lot of value addition for all the professionals attending this program, and probably in a small way would go on to contribute to make some changes in the lives of children with cerebral palsy. So this is one domain, as has been mentioned during the introduction, and this is how the title goes: Role of Functional Splints in Children with Cerebral Palsy. I myself, my professional career has it started with working with traumatic hands. Of course, it did not start with cerebral palsy, but it is almost a decade that I have started taking interest in stroke and cerebral palsy, splinting in these two domains. Before I proceed, for many, I understand the audience here are from different part of India, and this is where I am located. I hope all of you can see the cursor. I'm here at Manipal, Udupi, with southern part of Karnataka. We are on the west coast of India. So this is geographically, this is how I'm located, and I'm delivering this talk from this location. These couple of slides I would want to dedicate on occupational therapy and specific to technological intervention. So basically, my area of work is on splinting and low technology adaptive devices. The scope of today's presentation, of course, is limited to essentially limited to splints. Okay, so and functional splints. So it is with a little bit of twist as to what functional splints are and how they are slightly different from the splints that we often see. Now this is a health tunnel, and at the um, I hope my cursor is visible to everybody as it is moving on the screen. It will just help all of us to keep tracking as to which part of the slide I am mentioning to.
Yes, sir. Now moving now, sir.
Okay. Yeah. Thank you. So at the entry point of this, tunnel, it will be most of the time it will be a physician, okay, and the individual with deficits will step into this tunnel, and there are a host of professionals who would engage with the patient in different professional capacity, okay, and this is the exit point, and this is the functional realm of the society. Okay, as it was mentioned by Dr. Ganesh about the ICF. So ICF is all about the participation. Okay, so how do we engage back into the society? That is basically the key for in this ICF model as proposed by WHO. Now, at this exit point, what happens is the the patient's capabilities have to be chiseled out. They have to be refined so that they can suit the needs. There are a lot of defined needs, and there are a lot of untold norms of the working environment. Say, for example, eating. Now, the way we eat inside the confines of the home, the time that I take, the mistakes that I commit, it still is okay if when I'm doing in the confines of home. But if I have to eat at a public place, okay, then there are certain norms which nobody, of course, lists it out. Okay, but then we have to finish the eating in a particular way within a particular time, maintaining certain neatness. So these are this thing. I mean, uh, these are some of the untold norms. If I have to satisfy the requirement of eating in a public place, then I have to follow certain ways, methods, right? So to to be able to refine these capabilities, okay, there is a need to refine these capabilities, and probably then only we will be able to claim that the individual is participating to the fullest possible extent. Now, to be able to do that, we take help of technology. Okay, it can be in the form of splints, it can be in the form of assistive devices. Why it is low technology? Because as we all know, we exist in a resource constrained environment. Things are limited. Okay, our resources are limited, our finances are limited. Okay, our access to resources are limited. So there are a whole lot of limitations. So having said that everything is limited, it really doesn't serve the purpose. Okay, so it is important, it is the need of the hour that how do we circumvent, these limitation in all round resources and make the best of whatever is available. So that is the crux. Okay, and that is why I have taken these, specific interest in moving in this domain. That how do we create opportunities with whatever resources we have? Okay, so this vacant space that you see. This is the space of engaging. How do we engage with the patient? Okay, in terms of satisfy the aspirations of the individual, satisfy the needs of the individual, how everything is aligned. As a professional, we need to work as a facilitator. We need to be able to align to, it is not my aligning. Okay, it is we have to align to their needs and aspirations. Their needs and aspirations, both these words are very important, and they have to go hand in hand. Okay, so because my PhD studies has been on users' perspectives. So while doing this study, it really brought me very close to understanding these aspects and how important they are. So I believe that whatever might be my design and my creations, okay, they all needs to be, there's a need for aligning with the needs and aspirations of the individual. So this is a model that I believe for myself, and I try to keep it in mind as I get into designing anything. Now, this is another aspect when my topic is on functional splints. So, how do we identify function, and how do we um, you know, uh, pick up those elements of function, and how do we invest those elements, those identified elements, in designing the splint? Okay, so as you can see here, the screen is here in front of you, and there are these two letters, O and T. I mean, these are two alphabets, O and T. I'm an occupational therapist, so I have chose to mention these two alphabets, O and T. To the world, it is O and T only. You can't see anything beyond this, right? So now let us see what happens. Okay, so you can see here, right? So now in your screen, there is no OT, right? So what is there in front of us? It is uh, um, a kind of a blur image, okay? And you see in photographic language, it is called as pixels. Okay, you can see they are perfect squares. Each square has its own shade, right? So now the alphabet OT does not exist anymore. Okay, it is these boxes that exist in front of us. So that means what? That means human function, it comprises of numerous elements. Okay, human function comprises of numerous elements. So when an individual is presenting to us with a functional problem, as a professional, it is very important for us to figure it out that which all elements are compromised. Okay, and once they are identified and once they are picked up, then those elements go on to become the ingredient for designing anything. It can be design of a splint, it can be design of a device. Okay, so depending on what is our objective, objective is for remediation, then we'll go ahead with splint. Okay, remediating a particular function. And if it is low technology adaptive device, that is offered when the objective is to straight away compensate a particular function. So depending on what is our objective, we will have to take a call. So this slide basically I'm trying to emphasize that when we say that I cannot eat, it is a very layman's term that I cannot eat. It is the way that a layman, a common man will present to us that I cannot eat. As a professional, we need to pixelate that entire process, and we need to find out that which are the components that are compromised, and then we make use of that. Because we need to understand that I might have 10 children and all 10 are complaining of difficulty in eating. But the reason for for this difficulty can be very different for every single individual. So this is how this is how it looks like. Say in front of you, there is. I'm sorry about that. Sick. Yeah. Okay. So in front of you, you are seeing, you know, somebody wearing a sari. Now we all know that wearing a sari is a very elaborate process. It includes many steps. Okay. So it includes many steps, and each step needs a certain skill set. Okay. And when an individual says that I have difficulty in wearing a sari, okay, we need to find out at which step the individual is finding difficulty, or at which step it has got stuck. Okay. And when we say that it has got stuck, we need to find out that with the abilities, inabilities, how does it interact for that particular step? Okay. And can splint play a role? Like this, we have to craft out the splint. Now, this is the hand of a lady who is suffered a head injury. Okay. And you can now see how when this particular step, as we all know, this particular step of wearing the sari is called preparing pleats. Okay. Now, this lady, we managed to train the individual in a compensated way for most of the steps of wearing the sari, but eventually she got stuck in this particular process. Okay, it was not happening in a particular pattern, particular speed, with particular accuracy, because all ladies who wear sari, and is attending and part of this audience, you'll know that how important it is for having a very well finished pleats. Okay, so this is where this individual was getting stuck. So this is how we try to, profile the individual's functional challenges. Okay, and we capture elements from there and invest them for whatever design that we undertake. So this is our splinting unit, which is located inside the occupational therapy department, and these are some of the uh, highlights. Okay, and only therapists, they are involved. We make static, dynamic. The splints are made on the patients, so that is one of the key thing. Okay, it is not, splints are not made away from the patient. Okay, and that poses a lot of challenge, because when the patient is sitting in front of you, the patient, their family members, they are likely to give inputs. Okay, it is good and it is also difficult, because you know, the inputs can be constant, and you really need to be able to handle those inputs. We make 2000 to 2200 splints. Of course, this number has come down slightly, especially after COVID, for some reason or the other. And we design a lot of low-tech functional aids. So these are some of the highlights of a particular unit that we had developed in this university hospital, which is Kasturba Hospital, and which is incidentally, it is India's biggest hospital at a bed strength of 2,400. I mean, it is one of the largest hospital in the private sector in India. Uh, yeah, this is the definition. So we are talking about splint. So it is important that we also run through definition. There are definitions as given by many organizations. So this is as defined by ISO 1998, externally applied devices used to modify the structural and functional characteristics of the neuromuscular and skeletal systems by applying force to the body. Okay, so remember that a splint is a device that generates force. Okay, so there's a lot of mechanics that is involved, a lot of mechanics, biomechanics that are involved in this process. Okay, so splint is capable of generating force. So as a clinician, as an individual who is dealing in this domain, we have to, it is an art to play with the forces. Okay, we always have to make sure that the forces are pretty safe. Okay, and at the same time, the forces are producing certain meaningful changes. Okay, and at the same time, the forces are subminimal. Okay, and the forces should not cross the accepted, the barriers, the accepted norms, because it might cause, instead of good, it might cause harm. Now, the splinting, of course, this particular presentation, the scope of this particular presentation is splinting confined to neurological conditions only. Okay, so splinting in orthopedic conditions and splinting in neurological conditions, they are quite different. Okay, and uh, in orthopedic conditions, the presentations are quite straightforward. Okay, you have contractures. The reasons for contractures are pretty straight. Okay, the weakness, the reasons are pretty straight. But in neurological conditions, especially upper motor neuron conditions, where it presents with tonal abnormalities, okay, what happens is the contracture, the weakness, contracture, they all get mixed up with spasticity. And interestingly, both these phenomena are dynamic. Okay, so when one dynamic phenomena interacts with another dynamic phenomena, okay, it can be a cause of a lot of confusion. Okay, and so there is a need for a very critical analysis, very sharp capabilities of differentiating these two phenomena and be very, very clear as to the splint intervention is for uh, which component and how does it work. So this clarity, it may not be possible to discuss all these things within the time constraint of this presentation. But I mean, just it is a food for thought that splinting interventions are quite different for these two scenarios. Spasticity is referred to as a tightness or stiffness is a motor. It is a motor disorder marked by velocity dependent increase in muscle tone. I'm just jumping into these phenomena. I'm sure talking about cerebral palsy, there has been enough information that has already been shared. So I'm directly coming into the crux of the problem. Okay, so spasticity is one of the crux of the problem. So velocity dependent increase in the muscle tone or tonic stretch reflex associated with hypertonia. Now, these are the words that we need to understand. As Dr. Ganesh mentioned, that yes, splint, as far as the evidence is concerned, it has, evidence aren't that clear. Okay, they are not that evident. Okay, that splint doesn't work. Okay, but then why still to pursue? Okay, and so I will share with my case stories that I have here. Okay, and so here, as I'm sharing this particular slide and the next few slides on trying to explain these certain presentations which cerebral palsy children would be presenting with, okay, from the context of splinting intervention. Okay, so velocity dependent increase. Now, this is how in the splint we try to address this problem. It is velocity dependent increase in muscle tone. That means if a stretch is applied which is beyond the individual's capability of handling, the tissue's capability of handling, that means it exceeds the speed to which the tissues can adapt to, the speed is more, then the reflexes will react to that, and it will present to us as increased spasticity. Now, this we need to remember when we are designing the splint. Okay. Often here I would want to make an observation here. This is my personal observation, and it is that what happens is most of the time when uh, children with cerebral palsy, individuals with stroke, that means basically upper motor neuron conditions, when splint is being given, what happens is a therapist who is treating the patient is giving a prescription to a person who makes the splint. The person who makes the splint does not have direct access to the patient. Okay, or they do not view the tonal abnormalities, their exposure to understand the tonal abnormalities is very limited. So the person who makes the splint often is making the splint from the background of orthopedic rehabilitation. And this causes certain problem. And the person who is not making the splint, that means the person is viewing the patient's tonal abnormalities, contractures, purely from the viewpoint of giving therapy. So engaging with these tissues during therapy and engaging with these tissues through the lens of splint is quite different. Okay, which I will try to explain. These are much complex understanding. I'll try to share some of these things as I go through those slides. Okay, so as I'm reading this, just wanted to bring this to your notice and understanding. So velocity dependent increase in the muscle tone. So as a professional, when you're designing the splint, we need to understand that the splint, whatever angle we choose, we cannot exceed the the adaptability limit of the individual's tissues, okay, associated with hypertonia. It is a symptom and characteristic of certain neurological conditions. It causes certain muscles to contract all at once. Okay, so that means which we typically call as synergy patterns. So spastic muscles, they may contract as a group. Okay, there will be challenges related to dissociations. It ranges in severity and can affect movement and speech. This we all know. So there will be increased tone, overactive reflexes, lot of involuntary movements, okay, clonus. There might be associated pain, decreased functional abilities, okay, difficulty in the care and hygiene, abnormal postures, contractures, which is one of the key domains that we work with, and various deformity if they are there. So these are the various symptoms of spasticity. Now, when we give splint, okay, and when we measure the outcome of the splint, okay, when we measure the outcome of the outcome of a splint, how do we, which often is very subjective, how do we capture that, whether there is a splint is producing any change or not? There cannot be just one or two yardsticks. As a professional, we need to have multiple yardsticks, because which one is responding we do not know. Okay, and remember that the function, the quality of function, the challenges of the function, they all can get affected in various combinations of these symptoms that are presented in front of you. Okay, sometimes some component will be more, some component will be less. So in various permutations and combinations of these symptoms, it will it will it will finally be producing a functional challenges. Okay, so when we are giving splint, there will be a change in one or two or three. Okay, and we may not see major changes, right from the right from the state go, right? So that is why we need to have a very clear understanding of various symptoms with which the patient is presenting to us. So a splint performs all these purposes, protection, positioning, prevention, correction, functional, So why correction is in red? Because correction stands out, when the problem is very clear in front of us, and we make corrective splits. But the remaining of that, there is a certain overlap. People who are new to the field often might find it quite confusing. But then it is just to give you a sense that splints do present. I mean, they are used for these purposes. Okay, so now this is how a hand, the upper extremity will present to us. You can see here. Okay, so these are, a mix of spasticity and contractures. Okay, these are, involuntary movements, uncoordinated movements. Okay, so this is how I'm sure these images are extremely familiar to many of you. Many of you might be, actively involved in dealing with children with cerebral palsy. Okay, so they will be presenting to us like this. Okay, and how do we deal with these problems? Okay, now we need to find out that what is the objective, what is my objective for these hands? What is it that I would want to achieve through, by engaging with splints, right? So that understanding, that purpose should be well written in our thought process, because that will be the essence for whatever design that we undertake. Yes, as mentioned, you have this is a very famous article where they have clearly mentioned that we have very moderate quality evidence. Their benefits, and often those benefits are of uh, they are of small period. Their consistency, of lasting for a longer period of time, that itself is a doubt. But as I mentioned initially, that these are the challenges. Okay, so here it is not necessary that the author are making the splint themselves. Okay, that is, the treatment is by somebody and the splints are made by somebody else. Okay, and that when the information is shared, there is a very high chance, that there will be certain gaps. Okay, and those gaps are very critical. Okay, and that is where it can there will be certain losses. So here, splints were not well tolerated. Now, this is one of the key things when somebody is seeing the splint. I mean, somebody is treating the patient and somebody else is making the splint. This is what happens. Hand splints were not well tolerated in this population. Now, that is the crux. Okay, that we in our system at our workplace in Manipal, we have managed to, in a way, try to overcome that. Okay, where we make splints right on the patient. Okay, and we ensure that the compliance is to almost 100%. Okay, still we fail. But when the patient is leaving the department with the splint on, they I mean, we take these satisfaction from the individual, and that is why I'm quite happy to mention that we have patients traveling from almost all over India, to take splints from us. Okay, so using splints as an adjunct to activity. Okay, so there are different roles that the splint, this thing. So in conjunction to goal-directed training, so splint is not only a very passive piece of object. We make use of the splints. There are splints exclusively used for therapy. After that, they will not be using those splints. So there are a variety of usage of splints, and they will have quite a positive impact. So upper limb hand splints in conjunction with goal-directed training, carryover effect of the splint plus therapy. So the carryover effect we can increase. The ISF framework, as we all know, okay, that it is divided into two components. One could be the environmental factor, which is the physical support, that is the splint, and influencing the overall interaction, that is participation. So by manipulating the physical environment, we probably will be able to enhance the individual's ability to participate, which is one of the mandate of ICF. Pathophysiology of spasticity in the context of splinting. Chronic spasticity shortens muscles and alters the elastic properties of the muscle. So spasticity, as we all know, is a neurological phenomena, but it ends up producing, physical alteration of the muscle. Factors other than reflexive hyperexcitability may produce an increase in resistance. So that means what they are saying is the underbelly of spasticity. That means uh, when there is a spasticity, and when we try to stretch a spastic muscle, we feel a resistance, right? So what the author is saying is that resistance is not purely of spasticity. Okay, under the underbelly of spasticity, okay, there is a contracture that is gradually brewing. Okay, and even the contracture is contributing to the resistance as felt by the therapist. Okay. All the spasticity is neural in origin. As I mentioned, significant structural adaptation in the soft tissue occurs. And the contracture, as high as 30 to 40% of the cases of children's who, with cerebral palsy presenting with spasticity, okay, they will 30 to 40% of the cases will present with contractures. So the meaning, the interpretation of this particular slide is when we talk about giving splint in cases with cerebral palsy, there are basically two thoughts. One is how do we deal with the structural changes that has happened as part of spastic muscles, and the other is, which is little theoretical, how do we deal with some of the synergy patterns, how do we break those patterns, right? So when we break those patterns, it might be temporarily, it gives us the opposite group of muscles some breathing space, so if my elbow is always flexed, okay, and the biceps are spastic, they have undergone contractures, so it puts the triceps in a constant state of stretch. Okay. And it does not give the triceps any breathing space. So if I give a splint which will keep the elbow in extended position, okay, even if it is for a short time, the triceps will get some breathing space, and if they have some activity, within it, that is the time we can create, we can trigger those activities, you know, and that helps. And we have tried that out here. So why do we give splint in spastic conditions? So therapeutic stretching, okay, which manually is not possible. Okay, which manually is not possible because the stretch has to be gradual and the stretch has to be prolonged. Okay, which manually to do it is near impossible. Stretch gradually, the additional sarcomeres will make the muscle less sensitive to stretch. Okay, so as sarcomeres are lengthened, there is a chance the tissues will adapt better. Okay, then the child's submaximal range. That means the stretch always, and this has to how much stretch we provide. Okay, it is quite subjective. Okay, under no circumstances we stretch all muscles at all joints simultaneously. Okay, they are all measured. There are a lot of trial and error that goes into it. Okay, and at all time we try to play it very, very safe. Okay, so we never try to overdo any spastic muscle. Okay, so and that is how they will respond better. Stretch was most effective when it is applied continuously for time periods greater than 6 hours. So 6 to 8 hours, we call it as prolonged stretch. And to be able to reach to this level of 6 to 8 hours, it is a gradual process. It is not that we gave the splint today and you are expecting the child to wear it for 6 to 8 hours. No, it is never like that. Okay, we give the child enough space, enough room to get acclimatized to the new, splint that is been put on the body. It is not necessary that the splint has to, start working the moment it is put on the hand. We try to, especially for very young children, they will try to rebel, they will try to reject those devices, they will cry. Okay, so first and foremost, we try to put the splint as something as a playful item. Then slowly, it can take days together, it can take weeks together for them to get acclimatized to the splint, then to get acclimatized to the stretch. Okay, so it is a very gradual process. And the last is what is the purpose? To break the spasticity, contracture, spasticity loop. Okay, so we have to break these pattern. So these are some of the observations through different time period. Okay, what people have suggested, and these are some of the points which go on to become the cornerstone for the splinting decisions. Okay, I hope I am heard and the slides are changing.
Yes, sir. Yes, sir. Please continue.
Okay. Okay, so you can see here, it is my perspective of splinting. Making a splint is no big deal, but making a change in the mind and body, with the splint is a real challenge and is a big deal. Okay, so you can see here, of course, it is not a neurological condition; it is an orthopedic condition. So this is a hand, okay, and the image that you see here, you'll be surprised. This all these devices that you see in front of you, all these devices is for this particular hand. This is the hand that you see in front of you. It is the hand of an anatomist. Okay, she's a physician and she's an anatomist in one of the medical school. And this incident happened in Vishakhapatnam railway station. Okay, when she slipped between the moving train and the platform. Okay, and Of course, the train was very slow. It had just started, and this is the hand that got damaged. Of course, the train was, uh, 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 it was stopped, and nothing much. She survived, but her hands were affected. So when she came to us, and she was very specific in her complaint, in what she wanted from the hand. So she told three things. She said that I want to write on the blackboard because she's a teacher. I want to do cadaveric dissection, and I want to open my car door and my office cabin door. These three things are of great importance for me, and I need to be able to be independent in doing those things. Okay, so, and she wanted to hear yes or no. Okay, she wanted to hear yes or no. Okay, so, uh, and she said that if you say yes, I can go to any length to undergo treatment under you. And we said yes. And for the next 9 months, she was with us, and all these devices that you see in front of you, they all were given one to the next, to the next, to the next, like that. Finally, to arrive at this destination. Okay? So, this is the encircled object. Any guesses from the audience what it could be? Let me check whether my audience is awake or not.
Sir, I guess the options are unmuted.
Okay, okay, okay. Fine, fine. Okay. So this is a chalk holder. Okay, this is a chalk holder, and the chalk holder is designed to suit the hand exactly the way the hand was at the end of 9 months. Right. Now let us again come back to this philosophy. Making a splint is no big deal, but making a change in the mind and the body with the splint is a real challenge and is a big deal. So when I take these images out of the context, okay, out of the context, then you will, you might find, oh, this is just one such splint. But now when I shared with you the entire story, okay, and then when you see the background, then probably each devices goes on to create a life-changing experience for this individual.
Sir, a small interruption, sir. There was a chat saying that it is a chalk holder.
Yes, correct. So thank you for the person who responded. Now this is in front of you. I'm sure this is quite a familiar presentation. Okay, this is a CP quadriplegic child, and so when he came to us around approximately around 14 years, and he had a complaint that when will he eat by himself? And when I asked this, I mean, posed this question to my postgraduates and my students who were there around me, when I asked them that, when will this boy be able to eat by himself? He says that last 14 years, my mother has been feeding me. And it is becoming increasingly difficult for me to be able to witness that sight. With my mothers, I have other siblings. With this thing, my mother has to take out time and feed me. I make a lot of mistakes, and my mother has to this thing. So, will I be able to eat by myself? Right? Or do I have to wait another 14 years for me to eat? So this was a very compelling, question that this child presented in front of us. Now, if you see this small little image here in the inset, right? And the child is able to reach the spoon to the mouth. So once this image and this image, the difference is 45 minutes. In the next 45 minutes, the boy could put the spoon in the mouth. So how did we do that? So you can see here the splint. The splint takes into account different angles at the wrist. Okay. And there is an adaptation to the spoon. So a combination of splint and adaptation, this boy could do this task in the next 45 minutes. So this is how it can produce a result. Okay, so you can see here, this is the hand of an infantile hemi. It came to us, I think, so around 16 to 17 years old. Okay, so this is a hand which I'm sure it must be quite familiar to many of you who are encountering infantile hemi. As we all know, it is one of the category of cerebral palsy. And from my personal experience, infantile hemis have great prognosis, provided that we can catch them young and we can intervene with right kind of splints. So you can see here we are giving two splints. One is to stretch the biceps contracture, which is developed along with the elbow flexion, uh, the biceps, spastic biceps. And also, if you see this hand, okay, the typical posturing of this hand, okay, it is sum total of many things. It can be, um, uh, 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 you know, the extensors on the finger and the wrist extensors, they are pretty weak. There is a spastic long flexors, wrist flexors, and of course, contracture that has set in. Now, we need to disentangle all these components and find out that how we can target each one in a specific way, okay, and create solutions. And then probably we'll go on to merge things together. Okay, but if we are not able to disentangle every element, then we might be almost, trying to do things in a dark room, right? And then to give result will always be a big challenge. If you see here, this is a typical cock-up splint, but then this cock-up splint, many of you who are dealing with splints, either you're prescribing or you're making by yourselves, you may not have seen a cock-up splint look like this, but you might have seen hand like this. So why is it that you would have seen a hand like this, but a splint never, never a splint like this? Okay, the reason being, often the prescription for splint that is given and the person who is making it, they will make it as a typical cock-up splint. Okay, which is for a hand that has certain amount of the wrist can come to neutral, the wrist can go into extension, but long finger tightness, which is mixed with spasticity, that hand they will not experience. So they will make it from orthopedics point of view, and you will put it on a hand which is presenting with tonal abnormalities. Now this can cause problem. See, there is a statement here. I had to wait for 24 long years. This is the hand that you see of a CP quadriplegic boy. Okay, so this is the hand. Okay, and this boy aspired to complete his BCA, Bachelor's in Computer Application. Okay, and sorry about this. Okay, so then he kept on attempting on the keyboard, and you can see the wrist is subluxated, unsupported. and it will cause extreme pain, and he will give it up. This image you see, look at the splint. It is tattered, torn, and it is nothing special about it. But this statement that you see here, this is the statement that he makes, that I had to wait for 24 long years. You know why this splint is so tattered and all? You'll be surprised to hear that. He does not allow us even to repair the splint. His cupboard is filled with splints. This patient is from Bombay. He travels to Manipal, which is 1,000 kilometers. Okay? He travels and we give him this splint, the kind of angle that he wants, which will relieve of his pain. And at the same time, he'll be able to type in whatever way, as you can see here. He basically wants to be able to type, which is not painful. We need to give this solution. Okay? And you'll be surprised, finally, he completed his BCM. Okay, and the first post, the social media post that he posted, okay, it included me in his post with this hand when he typed the first social media post. So this is the kind of change that we are talking about, we are looking at. Now, this is a patient all the way from Hyderabad. Okay, so you can see here the, the patient presenting with a problem which is now they came all the way from Hyderabad. Uh, Hyderabad is approximately on the eastern side. We are located on the western side. Right. So this child is the case of infantile hemi, and the parents were quite concerned about the behavior of this limb. Whenever he performs anything on the sound side, the limb goes into these kind of posturing. So he was referred from Hyderabad. I mean, he was referred, family was referred from Hyderabad. When the parents started asking the therapist, when will my child's hand be all right? So they were quite insistent, both are IT professionals, and they were quite insistent to hear when. Okay. And this was quite puzzling for the therapists. Okay, they were quite insistent in that. And that was quite puzzling for the therapists, that how to tell when, right? So how to tell when is definitely puzzling. But then when we work in the domain of functional splinting, we might be able to search some answer to that. Okay, and this is an example of that. So somebody told that you can go to Manipal. And that is how, they flew down from Hyderabad to Manipal. Okay, and we first tried, we said that let us try. They came to us for one day, I mean, one full day. Next day, they will be leaving. Then they saw this, and this is day 2. Okay. So the splint was given not as a night splint, the splint was given as part of therapy. Okay. So you can see the performance now at day 2. Just observe it. You can keep it straight. Okay. Not only can he keep straight, when it is bending, he has a tendency of bending, he can attempt to straighten it out. And that is when the parents came and told that we are canceling our tickets. We are extending our stay here. You tell us how long we have to stay and what all splints you'd want to give our son. And for the next 2 days, this was a basket filled of splints that were given. Now, somebody might argue that why to load the patient with all these splints? Okay, so we loaded it for this very purpose. In the next 6 months, this is how the child's behavior improved. And this method of doing things the child was using more and more. in the child's day-to-day functioning. Okay, so these are all various functional and corrective splints. Here you see in front of you there is thumb in palm. I'm sure it is quite challenging for many of you when you are dealing with these children, right? So thumb in palm, it is obvious that if the thumb is occupying the entire space in the hand, no other object can enter into the hand. So it is very important that we, remove the thumb from inside the palm. So you can see here, this is the hand and this is the hand after around 2 weeks. Okay. So there are many activities that we do conduct with these splints. It is remembered that the splints are constantly being upgraded. They are redesigned. A lot of changes are incorporated. A lot of angles are, they are constantly being monitored, supervised. They follow up, right? So all these things we do undertake. So here you can see that how we decide on, this is a very, a trial run of how do we make the hand, enhance the functionality. So if you see here, this is a cock-up splint. We are just doing a trial and error. What we are basically doing is we are trying to find out what would be that perfect wrist extension, for the best performance of the fingers. Okay, and that angle goes on to become the angle of choice when we are setting, when we are um, uh, finalizing the splint. Okay, so this angle is of great importance. So, yeah, sorry about that video. So you can see here we are asking the child to make an attempt to hold this toy with that affected hand. But the moment he makes an attempt, this is how the hand starts behaving. Okay. So normally what we do is we'll go on instructing the patients, we'll try to set it up. But with splint, what happens is the human assistance, the human instructions, that is minimized. When human assistance and human instructions are minimized, what happens is the child can take his or her own decisions. We can facilitate those decisions. Okay. And it does have a positive impact on the child's cognition as well. And a better cognition can drive motor performances better. Okay. So that is how it will create a positive influence. So trying to catch them young. Okay, so any abnormality that we see, we try to deal with them at the earliest. The earlier, the better. Okay. Uh, as I'm discussing this, I want to assure the audience that at no point of time, whenever the splints are given, at no point of time, it will block the natural functioning. Okay. The splints are all timed properly. Okay. And we see to it that the child does engage with the natural environment in natural, whatever natural way possible. So that is always taken into consideration. So you see here, this is the kind of incoordination or lack of control. So the task given is, can he hold the hand on top of the bottle? Okay. So you can see here the difference in the performance. So with the splint on, what happens is he is able to engage in this task as a dual task. He can use the other hand and he can use the affected hand. You can see the time that he can keep the hand on top of the bottle. And you can look here the time. This is just one attempt. After that, his control just disappears. Okay. His control just disappears from that. Right. Now, we need to understand that there is a very important aspect of human function. When we talk about human function, there is something called as success and failure of the function. That means, now in this case, we want him to place the cap of the bottle on top of the bottle. Okay. Now, if he continues to fail to do that, it will impact him, his confidence, his motivation, even his cognition, everything will get affected. Because this is very typical of human function. He has to succeed. Okay. He has to succeed by himself. It is not human assistance. So in this case, when we are giving the splint, okay, he still has to make a lot of judgment, lot of motor judgment that he has to do. Okay, it is not human assistance. It is not that I am holding his hand and he is doing that. Right? When it is human assistance, there is a lot of problem. I mean, it needs a very different discussion altogether. Okay, so it is a device that is assisting him, and that is very different from a human being assisting. Okay. Now, if you see here, just a control. Okay, this is a boy with ataxia, and one task that we are trying to get is, can he hold his elbow in position and his forearm upright? That is what we wanted him to do. Okay, and it is very difficult for him. So if we are not able to create a position of stability, okay, to invest, that limb in some activity will be very difficult. Now you see here. Okay, you see both this thing. Okay, you can see the amount of time that he can control his elbow, in an upright position is much greater. Now, the moment he can even remember that when I say greater means even for few seconds is a substantial time for them, and we can use that few seconds, and then we can start building on that few seconds. Okay. So what is the philosophy? The philosophy is that when a person lacks control, okay, when a person lacks control, what happens is when that weak control has to control multiple joints, then that small control that exists in the limb, that will have no, I mean, it cannot do anything. But if you see here in this splint, what we are doing is we are stabilizing one component. What is that one component? That is the wrist joint. We have stabilized the wrist joint, and we, in a very small way, the splint is also ensuring that the forearm pronation supination also is stabilized. So when these two components are stabilized, now whatever limited ability he has, this limited ability he can invest in other joints. And that is why suddenly you see that there is a difference in the stability of both these hands. Okay. So you see here, so here he has to pick up these objects. So these objects he is able to pick up. Now you see this, yeah. Now he has to pick up this ball. You just see the interaction with the ball and the hand. Okay, now you see here. Okay. So you can see the difference. Right. So we are seeing that for many, you might think that what is so big deal about picking up a ball? Okay. So as a therapist, what we are doing is we are basically trying to create clues for us to create activities which are bigger. Okay. So like this, we try to find out what are the capabilities, how we can augment the capabilities in the hand. Okay. And that is how we work, and we'll these small capabilities, you know, like like blocks, like building blocks, they will go on to become bigger tasks that we will try to produce. Okay, so this is how I think. So I'm running short of time. The moderator may please indicate.
Sure, sir. You can continue.
Okay, fine. Thank you. Okay, so these are how it looks like at a very young age, few months old child to this thing. I have few slides which I've kept for lower extremity as well, although the main focus is for the hand. Okay, so these are all, remember that these splints that we make, they are quite different from the typical AFO that you often see. None of these splints are weight bearing. These splints, they are not going to use for walking. They are essentially when the patient is not on his feet, maybe nighttime or daytime when the feet is not on the ground. So these are typical TA stretching splint, okay, that we make. So this is for a small child, and this is, as we all know, tight TA is a big challenge for these kids. Okay, that will lead to them walking on their toes, and when they start walking on the toes, there are cascade of problems that will get triggered right at the knee, the hip, the trunk. Everything will get affected. So if we can deal with it at an early stage, get the TAs stretched, okay, and then we can make their walking pattern better. Okay. And if at all they want to undergo a release, the extent of surgeries will be less with better outcomes. It can be for the toes as well. As you can see here, they will have toes, claw toes, overriding toes, like varus, valgus. Okay, so a whole range of things, and there could be splints for that. I think so. This video is having a little trouble. Okay, but the image is this thing. This is a claw toes, multiple toes that will get affected. It can be problem related to the hip, knee. Okay, so you can see a CP diplegia. This is a case with CP diplegia. So they will present to us with tight adductors, uh, the tight hams. Okay, knee flexion contracture, tight TA. So the lower extremity can get involved in multiple ways. Okay, so there are different types of this thing. So you can see here the initial range. This is how we can achieve, and then we can go on to now the terminal ranges that will be dealt in a different way. So here you can see this is interestingly, this is a patient all the way from Kolkata. Okay, and what we are doing is this is a case of infantile hemi, and they all will have typical synergy patterns. So how will a synergy pattern look like? So this is how it will look like. This is how the child walks. Okay, there is a foot drop, and so toe stubbing is presenting with history of fall. You know, then you can see the upper extremity, this affected side, it is pronated, fingers flexed, elbow flexed. So like this. Now, how do you break this pattern? Okay, because we need to break this pattern and make the child walk under different patterns. Okay. In fact, this child that you see for walking, this is after all these intervention. Because before the intervention, the child could not walk without support. Every time at every step, the parents had to hold the child. Okay, so you can see here, this is breaking one pattern. This is forearm supinated, finger and wrist extended. This is stretching the TA. You can see here the TA is tight TA. Okay, this is thumb in palm. So there are multiple interventions that are possible depending on what they are presenting with. Some may present with hyperextended knee joint. This also is another challenge, especially for low tone children. Okay, you can see the severity of hyperextension. So to make it easy for them to allow certain flexion, so you can here. So this is how we can, because if they keep walking like this with a hyperextended knee joint, beyond a point they will not be able to walk anymore. We do make if children are presenting with self-mutilating behaviors, so we do work for them as well. So now quickly couple of slides and then we will end with it. These are adaptive devices. So all these while you saw splints, which are basically facilitator for a function. They directly do not play a role in a function, but these devices are for, which will directly participate on the function. So this is the case, as you can see here, there is an obvious limb length discrepancy. This is a young girl with infantile hemi, okay, and she wanted to help her mother in kitchen work, okay, and she wanted her mother to help her kitchen work, and that is when we start profiling on what is it that she wants, and she mentioned that she wants to safely handle hot utensils on and off the oven. So for that, we make all kind of evaluation, the kind of utensils that they have to use, for how many people that they have to cook, what is the weight of the various utensils, once they are cooking and once the entire meal is on that. So all these things are taken into account. Infantile hemi, as you know, that the patient does not have any control over the opening and closing of the hand. When somebody is handling a hot utensil, by chance the hand opens up, everything will fall. Okay, and that is the danger. So we need to create an environment and handling technique that is safe. So you can see here. Okay, so this is how, this is for a kadhai. Okay, so irrespective whether her hand is open or closed, as you can see here, just a little bit, yeah. So you can see here, that is the handle. Okay, you can see here. So irrespective of whether the hand is open or closed, the device will latch on to the hand. And we now trained the elbow. Elbow was better trainable. Now this is another utensil, okay, different kind. So this is an adaptive device with which directly they will be working. Okay. This is a child with very low tone. Okay. And he came to us almost at the age of 12 years. And the parents were concerned that the child is always lying, not wanting to this thing. So then we figured it out from by interacting with the parents that probably the child might have an interest, because for these kind of children, to find out what is the nature of interest, that itself takes a little bit of time, little bit of interrogation, little observation. And we figured it out that the child wants to, scribble. And you can see here, he did make attempt, but then because of lack of control over the pen, he gives it up and he does not pursue that. Okay. And this can be seen. Okay. So that adaptation enables him to put much deeper lines, longer lines. Okay. And in the image, you are seeing only the hand, you can't see the face. But we sitting there analyzing, we could see the face and we could clearly understand, the level of participation by the child. This is again another case of infantile hemi, and she made a special request that can I drink water with my affected hand? Because she has this desire to drink water while eating. And she does that with her right hand. She wants to drink water with the left hand. And as of now, she is drinking water. When she drinks water with the right hand, especially while eating, I'm sure many of you who in the audience, they will have a habit of drinking water while eating. Okay. And she's one of them. I am also one of them. Okay. And when she is holding water, the glass with the hand smeared with rice, sambar, dal, then the glass gets dirty. And that is causing a problem. Okay. That is causing a problem. So she wanted that can the affected hand independently hold a glass. Okay. And this is the adaptation. You might find that this adaptation is quite simple. Okay. But the challenge is the adaptation has to be created then and there. And the problem has to be solved then and there. So if she is, because these patients, they do come from great distances. Okay. And this has to be addressed then and there. It is the speed that is the crux. Okay. So uh, this girl is 17-year-old, and when she put the first sip in her mouth, she started crying. Why she started crying? Because her weight of 17 years, okay, that is over. So we need to look at this design from the context of 17 years. Remember that this request, it is not the first time she made this request. This request she has made multiple times. Okay. And finally, she gets an answer. So sometimes you can have really, really young kids. So if you see this young child, it is a 5-day-old child. We see 5-day-old, 10-day-old, all in the ICUs. And this tear stretching splint, I think so we have covered it. And yes, with that, I come to the end of this presentation. I'm sorry. I think so I exceeded my time.
Thank you, sir. Thank you for the nice practical presentation. So yeah, I just will make a small attempt to make a gist of what you have just said. So the introductory slide, it said about spoke about the health tunnel, where sir mentioned how the abilities of the patients has to be refined to meet out the patient's requirements and the expectations of the culture or society. Then we were told about how to identify functions in designing splints. Then there was a small introduction about splinting in Kasturiba Medical College, then how spasticity has to be taken into consideration in designing of splints. Then there were a few sessions about few slides about evidence on splints. Then there was a session on how splints are used as an adjunct to task-oriented activities. Then there were a lot of live examples, right from upper limb to lower limb, how splints can be practically utilized in a clinical scenario. So there are a few questions which we would like to consider, sir. So one question is from Dr. Aparna. She is asking about the foot splint that you have modified, the name of the splint that you have modified.
No, but there are multiple foot splints. If I get some clarity on what exactly.
I think the hammer toe one, sir. The foot deformity which you accommodated. That multitude, that crowding of toes you said about a splint.
So those are for multiple claw toes. Okay, so what happens is when the toes will claw, the tip of the toes will come in contact with the ground. So usually our toe pads have to come in contact with the ground, not the tips. So what we do is often these patients will come with ulcerated toe tips. So what this splint does is it lifts the toes up. It straightens the toe and it lifts the toe tip up. So that means for certain period of time, the toe tips are in the air and they get little time to heal. So that is how it works. So there are multiple holes through which we insert the entire the set of toes.
Okay, sir. Thank you. There is another question from a user Vivo 1990. Sir, is there a way to stop a child from continuously mouthing her hands and try to use them, especially a child who has got congenital visual impairment with CP?
Mm-hmm. Uh, maybe, I mean, um, on this question, my answer could be quite random and it may not be this thing. But what I really want is maybe if I could interact with the person and understand the nature of the problem, because just visual impairment and taking the hand to the mouth, uh, only that information may not be enough to come up with these things. We need some more information.
Yes, I understand that. Similarly, there was another question from another participant who asked you to recommend a splint for knee flexion for her 32 years old diplegic CP son. So I have replied them to provide with more information so that more concrete details can be provided.
Yeah,
Ganesh,
32.
Yes,
can
sir.
we do one thing? We will share all the questions to the Shovan sir, and he will answer them directly, or we'll post them in the group, and we'll make Shovan as one of the member of that group, so that any questions they have, they can directly interact with him whenever he is convenient. He can answer also.
Yes, sir. That's a good
That
suggestion.
Yeah.
will, if he has a time, because I know that he is a busy professional and it is difficult for him to instantly reply. But whenever he is free, that time he can reply into, so that many participants can directly interact with him. I think so. Instead of they may ask. See, I am receiving so many personal messages. That's a wonderful and excellent lecture organized by IACP, and we really thank you, Dr. Shonsa, and for your very beautiful lecture with a lot of videos where they can learn and enrich their knowledge. Especially functional sprints can greatly improve the quality of the life for children with the cerebral palsy and enhance their mobility, also independence and overall well-being. So you have a vast experience, and we are really thankful to you for sharing a very mm, elaborate and very a good lecture for the young professionals. Your dissemination of expertise really a great help to practice their knowledge. Thank you very much. And I request Trupti, if she is there, that we can say a vote of thanks to our esteemed guests and participants. Dr. Trupti? Trupti? Oh, she's I have to unmute her. I don't know. Today there is a lot of technical problems arised in the beginning. Uh,
Can you hear me, sir?
yeah, we can hear.
Yeah, yeah, yeah. Thank you, sir. Good afternoon, all. On behalf of ISCP, I will thank Dr. Shovan sir. We all know his knowledge in his sprints, and we have really admired his lecture today. It was really very informative, sir. Thank you so much. Thank Dr. Ganesh for moderating the session so well. All the esteemed audience here for interacting and participating actively in this workshop, and your attendance here for all the ICP webinars. Thank you all the esteemed guests here and our EC members. Thank you all and happy Diwali to all of you. Thank you, sir.
Thank you, Trupti, and happy Diwali to all participants. And this is a wonderful webinar today we had. A very pleasant evening. All of you, God bless you. If anything is there, you can straight away send us questions, or if you want to contact Dr. Shovansa, he is very all the time available, and is patient friendly and professional friendly and student friendly professional. And Dr. Durga Ganesh is there. He is also very friendly with all patients and students. Yeah, we can reach anyone, both of them at any time. You can drop questions in our WhatsApp group, or we will share his email, whatever, whichever is convenient for both of them. And Dr. Ashish Ghosh is there from AIMS Jodhpur. He is also very senior man, and all of us are there for you. You can share your questions or can clarify your doubts, or any interesting topic you would like to have a webinar from IACP, you can request us. All of you wish you happy Diwali. Thank you very much. Uh, God bless you all.
Yeah. Thank you all.
Thank you. Shall I end the meeting? All of you, please fill the form which I shared so that to get the certificate of participation.
Can I leave the meeting?
Yeah.
Okay.
I'm just ending the meeting.
Yes.
Thank you very much. Thank you, Dr.
for the
Shawan.
opportunity.
Thank you.